Good morning, everybody. We are so lucky to have Dr. Stephanie Blank with us here today. Dr. Blank will be discussing 20 medical advances in treatment of gynecological cancer in honor of Woman to Woman's 20th anniversary. In her talk today, Dr. Blank will highlight the growth and headway that has been made in the treatment of gynecologic cancer. Dr. Stephanie Blank is the Director of Gynecologic Oncology for the Mount Sinai Health System and is a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the Icahn School of Medicine at Mount Sinai. She's also the Director of the Women's Cancer Program at the Blavatnik Family Chelsea Medical Center at Mount Sinai and the Director of Oncology Programs, the Blavatnik Family Women's Health Research Institute. Dr. Blank specializes in treating patients with gynecologic cancers, including ovarian, fallopian tube, primary peritoneal, uterine, and cervical cancers, and in caring for women at increased risk of cancer. Dr. Blank, we are so lucky to have you here today. Thank you so much.
Well, thank you, Jillian, and thank you, Rachel, if you're here for the invitation. This is my favorite group, and I see some of my favorite people on here, so thank you for joining me. Next slide would be great. So just into personal disclosures, my institution gets research funds, but I do not have personal research disclosures. I'm going to probably mention some brand names and such, but I don't have any personal disclosures at all. Next slide. So yes, this is a discussion of 20 innovations, advances, or just changes in gynecologic cancer care for 20 years of Woman to Woman. They're in no particular order. I just tried to mix it up a little bit so it wouldn't get boring. It's not the past 20 years. There are really too many changes for that. Again, it's not organized, so don't try to read into it. And I'm sorry, I'm going to kind of rush because there's 20, so we can ask questions afterwards. And if I leave something out, it's just because I didn't think of it. It's not a slight or it's not important. It's not that it's not important. So next slide, please. So number one, I'm going to say minimally invasive surgery. Minimally invasive surgery is a big change in gynecologic cancer care. On the left here is a picture of laparoscopic surgery. On the right is the robot. It's a robotic assisted laparoscopic surgery. And we use them in all of our big three cancers, ovarian, endometrial, and cervical cancers. We use it probably the most in endometrial cancers. And it's really changed completely sort of the course of the initial course of a patient with endometrial cancer. It really results in the quicker recovery from surgery, fewer complications, fewer infections, less blood loss, and most patients actually leave the hospital the same day. So these surgeries used to be done with really large incisions, and now they can be done with much smaller incisions. So we'll move on to number two. Number two is Mirvetuximab. We sometimes also call it MIRV, or it's also known as Ella here. And this is something specifically that Jillian and Rachel asked me to speak about. So Mirvetuximab is a new drug that was approved last November. This is for ovarian cancers, for platinum-resistant, at this point, recurrent ovarian cancer. So this is a new class of drug called ADC, or antibody drug conjugate, and I'll speak about that in a little bit about exactly what that is. But again, this is a newly approved drug. And what I have here on this slide is just two figures from the study from which it was approved. And the reason I'm showing this is it's not to get technical, but the patients that were in this study were very heavily pretreated, which means they had a lot of prior treatments for their cancer. And the thing is that a lot of people responded. This is a very high response rate, and their responses lasted a very long time. Can I see the next slide, please? A couple months after their initial approval, to me, the slides look very big. Do they look really big? Oh, no, they don't. I'm so sorry about that. A few months after the initial approval, it became shown that not only did this drug shrink the tumors, but it actually made people live longer, which is really a big achievement in people that have had a lot of prior treatments. And this was really deemed a new standard of care. And there are a lot of new firsts about this drug. I'm making it sound like a panacea, and I'm sorry about that, but it's good to be hopeful. And so I think the message here is that there are new things coming, and I'll go further on that. So there's benefit in overall survival. It was a really specifically targeted new drug and a new class of drug. And so it's very, very exciting. Next slide. So this is a schematic of how it works. It's basically, it looks specifically for folate receptor. If you have that type of receptor on your tumor cells, and I'll speak about that in a minute. It gets kind of taken in right here. It gets taken. Oh, you can't see my thing. It gets in number 2, you see there, it gets kind of taken in by the cell, and then it basically explodes. Sorry about this, Jillian.
Number 2.
One bad thing about me not doing the slides is that I'm not going to be able to answer the little circle thing there. If you can go forward 2 things.
Okay.
Yeah. It gets kind of taken in there and it explodes, and then it basically turns like a pinball machine, and those cells basically start zapping other cells. If you can go to the next slide. So what does this mean for you? Basically, this is for people with ovarian cancer again. So how do you determine if you're a candidate for this drug? Your tissue gets tested, and so it could be your old tissue, it could be tissue from your originally diagnosed ovarian cancer, and it gets sent to a lot of different companies do this testing. At this point, there are 3 companies that I found that are doing it free. So they do it for free. And this changes which ones are free, but right now the ones that are free are Genomics, Serous, and LabCorp are doing it free. And so you can ask your doctor, and you can ask it when you don't need it. So you can ask it today, even if you're not on treatment, or you can ask it, if you're on treatment that's working, you can know it for the future. So it's worthwhile knowing if you have ovarian cancer, and you haven't had this done already, it's worthwhile. Next slide. And so what does that testing show you? So folate receptor alpha is overexpressed on a lot of ovarian cancer, but the thing that you need to have to be eligible for this drug is you need to have high expression. And this is sort of what it looks like: low, medium, high. It's like a stain that they do on your actual tissue. And if you're high, it's considered positive. When they first took this drug out and looked at it, they were looking at everybody that had medium and high, and it wasn't working that well. So it's really when you have high. So you don't want to say like, oh, please, can I have it? I have medium expression, because it's not going to work as well. It's really high. Next slide. And this is sort of what a report will look like. It'll say, oh, you're positive, and then you'll know you're a candidate for this specific drug. Okay, next slide. Okay, so that's some exciting things. So number 3 is just the molecular classification of endometrial cancer. So we used to think of endometrial cancer just as looking how it looked under the microscope. We used to call it type 1 and type 2. It could be endometrioid or it wasn't. And basically we sort of said, you're going to do great or you're not. And we were oftentimes wrong. But now using these molecular classifications, which is basically we sequence the tumors, we can tell a lot more about how somebody's going to do, what the right treatment is, and everything like that. Now, right now, the slide is too big for me. Is it too big for other people too? Thank you, Jillian. Sorry, I don't mean to be picky.
No. Is that okay?
Yeah, that's good. Thank you so much.
No, of course.
So that's number 3. So this is a big change, and it's continuing to be a new change. And actually, there's new staging of endometrial cancer that is going to incorporate these factors. Like, an important thing about endometrial cancer is this group on the far left, POLE. If you have a mutation in POLE, it's called, your tumor actually is known to have a really good prognosis, and you probably don't need as aggressive treatment as some people need. So it's actually really useful because it's going to allow us to treat some people less. Some people aren't going to need as much treatment. I mean, most people don't need a lot of treatment with endometrial cancer, which is great. But to know that some people, even if by traditional factors you would need treatment, if you have this mutation, you might not. That's really kind of exciting that we can learn to de-escalate treatment. Next slide. Okay, I think this is number 4. This is the new class of drug called antibody drug conjugates. And these are the components. I just wanted to explain it. There are 3 components to these drugs. One is an antibody, and that's this part that's in green and blue. And that is highly selective. This is a monoclonal antibody, and basically it's going to look for a specific antigen that's like a little, almost like a door on the surface of your tumor cells. And then there's a payload. And this is something that is really super toxic. But while it's in part of the antibody drug conjugate, it's in an inert form. It's not going to work yet. And then there's this little part here that's called a linker. And it sounds really like it's not so important, but that's the thing that keeps the payload kind of in its latent form. So what happens is the antibody gets to the cell, and the cell then kind of eats it up, like I showed in that other thing. It kind of envelops it. It gets into the cell. The linker, releases this payload, and then the payload goes crazy. This payload, if it was open, would be much too toxic for you, for the body to take. But when it goes in the cell like that, then it sort of releases and it allows it to work. So you have this very targeted therapy, and it won't go to cells that don't have that thing on the outside. So it works pretty well. I mentioned this one, Ella here, or Mirvetuximab, which is now approved for platinum-resistant ovarian cancer. There's another one that's approved in cervical cancer called Tivdak, or tisotumab vedotin, and that's a really big advance. That too has recently been shown to have an overall survival advantage in cervical cancer, which is a huge deal. We don't have a lot of drugs that do that in cervical cancer. And I think I'll speak a little bit later, but there's a really promising one, again, not FDA approved as yet, that targets HER2, that has been looked at in a whole bunch of different tumors and has been extremely, extremely exciting. I think it's FDA approved for breast cancer at present, but we're really hoping that it gets approved in other cancers as well. Next drug, I think this is number 5. So number 5 is focus on survivorship. So it is a big advancement that we're not just looking at, survival curves and things like that, and counting months and years, but we're actually looking at what happens to the human being once they've gotten through their treatment. So there's a lot of things that you're dealing with aside from chemotherapy. We're looking at how are you living, what's happening on a daily basis, and I think that this is a huge deal. These types of research is funded on a national level. It's considered a mark of quality of a cancer center. You have to focus on these types of issues. And I think it's really speaking to the fact that you're not cancer, you are a person. This is a huge advance, honestly. Next slide. Number 6. I've heard criticism that people are sick and tired of just hearing about PARP inhibitors. This is the only slide I'm going to talk about with PARP inhibitors, because not everybody can take PARP inhibitors, okay? But I wanted to just bring this one up because this was shown recently, and this is the longest term follow-up we have with PARP inhibitors, and this really showed, this is one of the earliest studies, SOLO-1, and this showed in people with BRCA1 mutations, they reduced the risk of death. Sorry to use the word, but it is long-term follow-up by 45% in patients that took them for 2 years of maintenance. So it's really pretty profound. And this is over, 102 months, so 8+ years of follow-up. So it's really profound. And the other thing that's important is that the placebo group here, 40% of them actually took PARPs after it. So we actually learned that it's important to take them early. So we really think maintenance is very, very important. Next slide. I lost count. I think I'm on 6 or 7. I'm sorry. I'm going to stop counting now. So this, I can't say it's
so great. Thank you.
What's that?
I just want to say that this is so great. So thank you so much.
I lost count. So sorry about that. It's like, I swear I have 20. I counted it like 6 times. So I'm not going to say this is an advance, but I think it is. So these 2 slides go together. So this is changing demographics of the people that are treating you. So the SGO is the Society of Gynecologic Oncologists. These are gynecologic. So gynecologic oncologists. So there are now, just over the past, well, now it's 23 years, but there's been a changing demographic in men and women, from predominantly men. And before that, it was even fewer women, but now there is a majority of women in this field. And that is a definite change. I'm not going to go through the statistics about women doctors because it would be very self-serving, but I do think, that, it's not only in terms of gender, but there's an increasing diversity in terms of race, ethnicity, and everything else. So I think that is a change, certainly. Next slide. And this is the only other thing I'll talk about in terms of your providers. But, there has been also, it's not only in terms of gynecologic cancers, but in terms of all, providers, physicians, there is an increasing attention to the fact, the true reality of physician burnout. And that's something that's been looked at, from, at the Society of Gynecologic Oncology, but also at the National Academy of Medicine, and a true focus on the fact that if providers are burnt out, they actually do not take as good care, it affects their patients. So I think the fact that, there is a true focus on the need for people to take care of themselves, I think that is really important. And that is an innovation in some ways. Next slide. Radiation, there have been many advances in radiation. There used to be what these things at the bottom are sort of how radiation is planned. If you've had radiation, you know that you first go into a CT scan, or initially here this is shown as a CT, but it used to be done through x-rays. And that's how they would plan where you need to receive the radiation. But with advances in technology, they've been able to really hone in on what needs to be radiated and what can be spared. And what that has done is really minimize the side effects of radiation. If you can spare areas from radiation, you don't have the effects on the areas that didn't need the radiation. And this has been a huge improvement because, the effects of radiation can occur years out. So you want to really radiate exactly what you need and not more. So what we've been able to do with improvements in radiology techniques is narrow that. Next slide. Immunotherapy. Immunotherapy is a huge, huge advance, and that has been across multiple cancers, but in gynecologic cancers specifically, I'll say the biggest areas for that have been cervical cancer and endometrial cancer, where there are approvals in this area. When I say approval, I mean there have been studies that have shown, true benefit, and the FDA has looked at them and given approval so that you can get them easily through your insurance will approve them and that type of thing. So in cervical cancer, there have been survival benefits shown with pembrolizumab when given. It can be given alone, and it can be given with chemotherapy. There is actually approval for all of our cancers if you have something called microsatellite instability in your tumor. It's generally can be associated with Lynch syndrome, but it can also be associated with other findings you might have in your tumor tissue. And then in advanced endometrial cancer, it was recently approved to be given with chemotherapy in the front line. And it's also given in recurrent endometrial cancer with another drug that is a pill. And this is really a huge change in the treatment of these cancers. Now, something that's a little interesting about a lot of these treatments, we talk about maintenance, we talk about immunotherapy, is sometimes we used to give 6 treatments and you're done. A lot of these are given for a much longer time. They're sort of a maintenance. But something else interesting about that, to be able to be given a long time, they do, and some people might be on these treatments and they might not agree with me, and if so, I apologize, but they tend to be more tolerable than some of the chemotherapies that people are on. So that is or maybe you learn to live on them better, I would say. So and basic, can you go back one slide? I'm so sorry, Jillian. So there are different forms of immunotherapy. The ones that we use a lot and that are used probably the most in general are immune checkpoint inhibitors. That they're the ones that kind of work in terms of the mechanisms of how cells talk to each other, and that's where we have here. And this one's advertised on television a lot, but that doesn't matter. It still is a very good drug. Next slide. Another advancement is that we really have impacted the incidence and the mortality of ovarian cancer. So we've decreased the number of cases of ovarian cancer via birth control pills and by learning about who is at increased risk and performing risk-reducing surgery. And we've, limited the number of deaths by having better treatments and especially for disease that comes back. So this is really encouraging. I'd love to see curves like this for endometrial and for cervical cancer going forward. Next slide. A huge advancement is.
I'm so sorry. Oh, I'm so sorry, but there's a couple people I'm unable to mute. So if it's possible, please everyone mute so that way there's just no feedback and we can hear Dr. Blank a little more clearly. Thank you.
SHAO. Mount Sinai. No, I'm being treated with this 2 times at Mount Sinai, and then I'm doing the
I'm trying
trial
to mute it too.
with
I don't know what to do. Shall I continue?
Right.
Sorry, Jillian, can't hear you.
If you can, sorry, I was muted. If you
Okay.
can.
I'll speak
I took
loudly. I'm
your
sorry, I don't
test
know what else to
yesterday.
do.
And the results, I know you have difficulty seeing them for the first couple of days. So.
Okay. So
Jillian, can't you mute people yourself?
It was
Some
pretty
people,
bad.
if I can, I will, but some people I'm unable to, whether it's the kind of device that they're
Well,
on.
the protein went down, right? From 100
Those
to
that I'm able
I
to,
think it's the iPhone.
I've had 69. Okay. All right. A huge advance is the HPV vaccine. As you know, cervical cancer can be eliminated, but just specifically, the World Health Organization has a global strategy to accelerate the elimination of cervical cancer as a public health problem. This is really exciting. They're talking about eliminating cervical cancer by the year 2030, and they have basically a 3-pronged approach. They want 90%, it's 90, 70, 90 or 70, 90, 70. I can't tell because it's not up there. Can you go forward more? Sorry. Thank you. It's 90, 70, 90. They want 90% of girls fully vaccinated with HPV vaccine by age 15, 70% of people undergoing proper screening with a high performance mechanism, and 90% of women with cervical cancer being treated appropriately. And that's really important because you can say, I want everyone vaccinated, but you're still going to have a lot of people that never got vaccinated. You have to think about all the different kind of groups of people. You have to take care of the people that have not yet been exposed to HPV. You have to take care of the people that are in screening. You have to take care of the people that already have cervical cancer. So this is a huge global effort, and it involves the NCI, it involves the SGO, it involves a lot of global organizations, and it's very exciting when you think about it. So huge, exciting effort. Oh, I'm trying to advance the slide. Thank you. Genomics is another huge advance in the treatment of gynecologic cancers and all cancers. So genomics, you can look at genetics in the blood, you can look at genetics in the tissue, and soon maybe we'll also be able to look at sort of circulating tumor DNA. So through genomics, we can see if you had a genetic predisposition causing the cancer in the first place. If so, you can talk to family members and they can maybe prevent their cancers. Through tissue testing, I mentioned a little bit before with endometrial cancer, but you can target your tumor for certain drugs. We've basically been able to really hone in on why your tumor turned to cancer and sort of focus on that mechanism. You can also, it's not really ready for prime time yet, but there are some ways that you can sort of follow what's going on in your body through blood going forward. With something like a PARP inhibitor, if you're on a PARP inhibitor and you stop responding, we can maybe use genomics to figure out why that is and undo it. So that's those are sort of exciting ways to think about it. Next slide. An exciting thing to think about, another advance in the care of people with gynecologic cancer is shared decision-making. Like the old model was basically paternalistic. Your doctor said, do this, and you did it. There was another way where your doctor says, these are the choices, you make it. That's not always the best either, but shared decision-making is your doctor gives you information and recommendation. You say, this is what I value. This sounds good to me. And you work together to make your decisions. It's basically a collaborative process that allows patients and the healthcare team to make healthcare decisions together. It sounds fairly simple, but it's a fairly new concept. And it requires something called communication. And something else that's new is, next slide, please. is that communication is actually valued as a part of medicine. So I think that it sounds very simple. And I guess some of the things that I'm talking about today are for medicine in general, not only for GYN oncology, but I do think that they are changes in medicine. Next slide. Another change, another advance in gynecologic cancer care is the tubal theory of ovarian cancer. We now think that most high-grade serous ovarian cancer actually starts in the fallopian tube. This is sort of a schematic of it, that it starts here and basically sort of sprinkled onto the ovary, and then it kind of seeds through the abdominal cavity. We think the reason why we think this is because when we do risk-reducing surgeries for people with increased genetic risk for ovarian cancer, we do find tubal precursors in the tubes. And then when we process these in a specific way, looking at the microscopic cancers, that's what we find. Next slide. This leads us to sort of two thoughts about preventing cancer. One is the idea of risk-reducing salpingectomy. That means removing the tubes to prevent cancer in people at increased genetic risk. Normally, for example, or the traditional recommendation is if somebody has a BRCA mutation, that's a mutation that predisposes people to ovarian cancer. We recommend they have their tubes and ovaries out at age 35 to 40 or when they're done having kids. And that's a very early time to go through menopause. But we now have a study that we're performing here where people can have their tubes out at that time. So they get some risk reduction, we think, but not menopause. So that's a very exciting study. And if you have a BRCA mutation, tell everyone in your family that fits these criteria, because it's a 2,000 person study going on for 20 years. It's the only way to answer this question. Now, the other way that you can think about removing tubes as potentially preventing cancer is something called opportunistic salpingectomy. And this was in the newspaper in like February. It got a lot of press. But this concept is if you're having another surgery for another reason, generally in gynecologic surgery, we remove the tubes at the same time. Removing the tubes doesn't really cause any hormonal changes at all. But if you believe that picture that I just showed you moments ago, it could prevent cancer. And what I'm showing you here is that in Canada, there was a large campaign to get people to do this. And what it showed was about a 60% reduction in cancer in serous, that's the cell type, serous ovarian cancer. And meanwhile, their breast cancer and colon cancers were exactly the same. So it does seem to actually work. So that's actually pretty exciting. Next slide. This is another advance in gynecologic cancer care. And this is something called enhanced recovery after surgery. And this is why people go home now 2 days after a hysterectomy, whereas you used to hear people staying for 10 days. So this is the whole concept of you get up and walk day one after surgery, you're eating food day one after surgery. This is a whole different approach to care in the hospital after surgery that's all based in stress hormones and glucose and chemistry, and it's very it sounds really radical to people, to older people that have been practicing a certain way for a very long time, but it has a lot of evidence behind it. And so this is funny to me because it says addressing implementation challenges, and that's usually the people in your group that practiced a certain way for a very long time. But this has really been shown to diminish complications. So it's a big change. Next slide. This is about fertility. So the whole, this doesn't usually belong in an oncology talk, but the whole concept that if you have a person of fertility age and they have a cancer diagnosis, that you don't just have to say, well, forget it, that you can talk to them about fertility, that you can sometimes preserve fertility, either, even leave them with the ability to have children afterwards, or if that's not possible, to have them speak with a reproductive endocrinologist to be able to freeze some eggs for use later. The idea that if you have a genetic predisposition to cancer, that you can harvest some eggs, make some embryos, and potentially check those embryos to make sure that you're not passing on that gene these are huge advances in the field that were not even thinkable 20 years ago. I know I said it wasn't 20 years, but they weren't thinkable, and those are huge advances. Next slide. Less is more. The whole idea that surgery is much less radical. A couple of examples of that. The idea of sentinel lymph nodes. We used to, for example, for endometrial cancer, we used to remove all the lymph nodes in the pelvis and in the periodic area. So that's a lot of lymph nodes. We used to get like 30 lymph nodes when we were doing a surgery. Now we inject some dye at the beginning of the surgery, and we try to take one from each side. And the reason there's two reasons to do that. One is that there's much less of a chance of something called lymphedema, which is swelling in the legs. After it can happen at any point in time. And the other thing is we take that one lymph node and we do special staining and special processing, and we got a lot more information from that one lymph node. We used to do very, very big hysterectomies for cervical cancer, and now we've learned that we can probably do smaller ones. Same thing with surgeries for vulvar cancer. So basically, we've learned that we don't have to do such big surgeries all the time. People do just as well, and they have better recoveries and better quality of life going forward. And the minimally invasive surgery is another piece of that. Back to HER2/neu. HER2/neu is a marker. You hear about it a lot with breast cancer, but it's been very important in gynecologic cancers for the past, we've learned it over the past like 8 years or so. An important one is trastuzumab. The other name for that is Herceptin, and that is used a lot in breast cancer again. But it has been shown to have a survival advantage in people that have uterine papillary serous carcinoma. So that's a picture of the molecular structure. Sorry, it's not that pretty, but I didn't know what else to do. And then the Destiny pan-tumor study is the one I was mentioning with, that's the antibody drug conjugate that had this amazing, this picture is I thought it was pretty because of the color. I should have made it a little bit bigger, but all those triangles going down are thank you for that, Jillian, you made it bigger. All those things are triangles going down, are tumors shrinking. I mean, that's an amazing response to that antibody drug conjugate we have there. So that's really, really, really exciting. You don't usually see things that look like that.
I'm so sorry. I lost
No
it.
problem.
1 second. While trying to make it bigger, I then.
No, I appreciate you making it bigger. That was good.
Give me just 1 second.
I know what my next thing was, so I can sort of explain it while you look for it, because it's on slide 30.
Covered so much.
Thank you. So slide 30, sorry for that's good. So slide 30 is a change in the way that that clinical trials are done. So traditionally, if they had a design, they were conducted and they were analyzed, but unfortunately, by the time they were analyzed, the next study would be already in the works, and it might have been designed based on presumed results of the prior study that weren't accurate. So the idea that you can have what's called an adaptive design, that you can look at the study as it's going on, and maybe adapt the current study or use that information for future studies, allows the science to progress a lot quicker. And if you think about the fact that patients who participate in trials, and thank you for that if you have or are a huge resource, it's very important that this be done. We want to get answers, and we want to do the right thing as quickly as possible. So just really being creative and thinking about the best ways to get to the answers as quickly as possible is a big advance here. Next slide. The next advance, and this is 2 slides, but we'll stay on this one, is the number of drug approvals that we've had in our cancers. And this one is for ovarian cancer. And this is over time. There's been more approvals in the last, I think, 16 years than we had in the past, 40 years before. So, I mean, there's been a huge explosion of approvals in ovarian cancer. The last one is here, Mirvetuximab, which I just mentioned. And next slide. And these are FDA approvals in all gynecologic cancers. They're color coded by which condition they're associated with, but there've been certainly a lot, and you can see they're all weighted towards the right, which is now. So that is a lot. I think what does this mean? This means drug companies are taking an interest in our cancers, which is really good. I think researchers are taking an interest in our cancers, and the FDA is interested in our cancers. They're looking at different endpoints. They used to only look at overall survival. Those studies took a very long time to complete. So now they're looking at some other endpoints that are a little bit quicker. I don't want to get too technical, but it is a very big deal. And the reason that they're doing that is from a lot of lobbying, actually from some survivors and from some gynecologic oncologists, to make them look at things quicker. Next slide. Oh my goodness, I'm almost done. This is number 20. So number 20 is that, it's a team that cares for you, and you are not alone. There are people that help you in so many ways. The same way that we were talking about quality of life, focusing on that as being a big part of cancer care. There are all these people that work with you to help you just do better, live longer. And next slide. And you're not in this alone. And a program like Woman to Woman, and they didn't ask me to plug Woman to Woman, by the way, but a program just as together and as thoughtfully strategic, everything put together as Woman to Woman can really just be such a resource that exists is a huge innovation. And I actually think just the way that Woman to Woman just so beautifully transitioned, at COVID, and now has become something that people can use. I don't mean use, but whatever the word you might want to say, but just that it's such a accessible resource. It's just great. So anyway, thank you for this opportunity. I hope it wasn't too fast and or silly. So we decided 20 things would be a good way to do this. So thank you.
Thank you so much, Dr. Blank.